15 minutes or every 10 minutes, I'll just stop sharing and I'll just open the chat box and we can have a discussion about any questions which are there so far, or if anyone remembers anything they have to ask me about, then we can have a discussion. So I won't give a lecture which was very intense or bracket boring for 1 hour as it was last time. So before I put you all to sleep, which is very much there in the lockdown, so I'll just try and make it more interactive. Okay, so let me start with rotator cuff. I just forgot how to start this. Okay, so I always start my video with guess the side. If you have attended one of my sessions for physiotherapy, then maybe this is the same presentation. So the 36-year-old male who had a history of long head of bicep subluxation, partial tear of the subscap, a subacromial spur, was earlier tried conservative treatment. He had tried a fair bit of physiotherapy. He tried scapular strengthening. He tried range of movement. He tried a lot of exercises. He wasn't very happy. Ultimately, his MRI started showing subscapularis tear, which is an absolute indication for surgery, because what happens is maybe I'll explain it further in my talk. The long head of biceps further keeps tearing the subscap, and that's where you have to probably go ahead and fix it before it is too late. So that's what we did. We operated him with the use of an arthroscopic biceps stenodesis and did a subacromial decompression at the same time. So this is his video 3 months post-op. This is his second video 3 months post-op. Oh, sorry, 5 months post-op. And this is his third video, which is a 5-month post-op. So basically, I always show this and ask the patients as to which side have I operated upon. Ask the physiotherapist basically which side I operated, because the patient was, the patient ended up doing his rehab so well that he did not, have any sort of difference between his operated side and his normal side. So both his sides were fully functional, having equal strength, equally pain-free, and he was equally comfortable in doing all the intense physical activity which he wanted to always do, and that is the reason he got operated for. So one most important thing which we should remember before we commit a patient to an arthroscopy or before any sort of shoulder surgery is that shoulder is a very sensitive joint. Shoulder, once we decide to operate upon, we should be fully committed to do the physiotherapy till we get him the desired result. Shoulder is very notorious for getting stiff post-operative. May it be a fracture fixation, may it be an arthroscopy. Any sort of intervention in the shoulder and the capsule starts thickening right at that moment. So physiotherapy plays a very, very crucial role in a post-operative shoulder patient. So always remember that any sort of patient you encounter who has undergone a shoulder surgery recently, you have to be very aggressive with him. It may be controlled and supervised, but it has to be aggressive at the same time. Similar case, 76-year-old male had a massive rotator cuff tear. What is massive rotator cuff tear? He had at least 2 to 3 tendons which were torn, the supraspinatus, the infraspinatus, and a fair bit of teres minor, with partial thickness of subscap, with long head of biceps tendonitis. So he had moderate muscle atrophy. Again, we operated him with a arthroscopic rotator cuff repair. We have a series of massive rotator cuff tear who are actually advised reverse shoulder arthroplasty. But my philosophy about a reverse shoulder arthroplasty should always be as a reserve procedure. So joint replacement in shoulder should not be done commonly if there is even a 1% chance of repairing their original muscle. So I always try and preserve the shoulder as much as possible. So this was the same patient, a patient who was not able to lift his arm. He was literally having a pseudo paralysis. So if you see, this was what he was actually able to do before. And 4 to 5 months later, just a minute, sorry. I don't know what is happening. Yeah, so I hope everyone can see it. So if you closely observe, this patient has a slight lag on the right side, and that is the operated side. So the left side is absolutely normal, but the right side, not easily noticeable, but that is where he had a slight lag, and that was which was operated upon. So can you see the full range of movements? Okay, so this is where he has active external rotation. Why did I show this active external rotation? Because the patient had an infraspinatus and teres minor tear. And once he's able to get this active external rotation, that means it's completely healed and the strength is reasonable. I'm not saying he's going to go and play football or any sort of overhead sports, but he's gotten his active external rotation with which he's able to at least wash his hair, eat his food, and extend his arm completely up. So this patient, 7 months or 6 to 7 months post-operative, was able to ride his two-wheeler and come to the clinic for a follow-up on his own without his, without the need of any assistance while driving the vehicle. So that is what he wanted to achieve. That is the kind of independence he wanted to achieve, and that is what we have given him post-surgery. So let me start with rotator cuff. So rotator cuff is a group of muscles which dynamically stabilize the humerus within the glenoid. It is the most common cause of shoulder pathology in adults more than 40 years. It's a very, described in 1884. It has been happening since ages. So we normally consider the shoulder to have, apart from the deltoid, which is a superficial muscle, the deep muscles of the shoulder consist of the supra, infra, teres, and subscap. So why is subscap separate? Subscap is separate because it is the only anterior muscle. The supra, infra, and teres minor are the external rotators. So they play antagonistic roles, but they are synergistic with each other. So it is a dynamic stabilizer. They always start the abduction and they depress the head, providing a fulcrum. So rotations are possible in both the planes, internal as well as external rotations. As I explained last time, the long head of biceps is very important in the shoulder for two particular reasons. One is it is a part of the biceps which is intra-articular. So the short head of biceps starts from the coracoid process, but the long head of biceps passes intra-articular. It is just 10% of the total bulk of the biceps, but the 10% can cause a lot of shoulder pathologies. So treating the biceps problem is very crucial in dealing with shoulder pathologies, and that is a very painful muscle amongst the other rotator cuff muscles. Inflammation of the biceps can also lead to overall bursitis inside the shoulder. Hence, it is not just the biceps which you are treating, but you are also treating the subacromial bursitis along with it. So just treating the biceps and treating a subacromial bursitis will give the patient complete relief from most of the problems. So rotator cuff disease is usually caused because of intrinsic or extrinsic factors. The intrinsic may be because of ischemia, higher age. Extrinsic factors. Now this is a very important topic to discuss because this will be the bulk of your practice. This will be the majority patients which present to you. It is with this flow chart. The patient starts with having some impingement, ultimately develops some bursitis. Then it can lead to a partial tear, a complete tear, and a cuff arthro. So what is impingement? Impingement is basically the acromion or the AC ligament, which is basically impinging upon the rotator cuff muscles, causing them to develop some kind of an abrasion, which lead to irritation in the shoulder and lead to pain. So impingement leads to bursitis. The subacromial bursa becomes inflamed. Repeated impingement can cause some sort of a partial tear inside the shoulder. Eventually, the partial tear may develop into a complete tear. Complete tear, if present since a long time, will develop a cuff arthropathy. So why is cuff tear important? Cuff tear is important because it unbalances the shoulder. So if your supraspinatus or subscapularis has torn, then probably one motion exceeds the other. So the anterior balancing force, if it is absent, the shoulder tends to move more anteriorly, and that unbalanced force causes arthritis. Hence, a supraspinatus tear should not be left unattended because it leads to an unbalanced.
आता काहीच नाही, जिथे जागाच नाही actually.
Okay. Apart from that, one very important thing to remember is a lot of people must have encountered patients in their practice and a patient with an MRI report of a complete cuff tear. I mean, I have seen a couple of patients in my OPD. MRI says complete supraspinatus tear, but the patient is absolutely pain-free. He's able to completely lift his arm. He's complaining of intermittent pain, but really not bothered too much by it. I tried to convince him for surgery because there is a supraspinatus tear, but the patient is not completely convinced. Then what do you do in such cases? So number one, a painless supraspinatus tear, which is not increasing in diameter or not increasing in severity, can be left alone, provided the patient is very comfortable. But in such cases, you need to continuously monitor the patient with repeat sonographies or repeat MRI. So you cannot leave a supraspinatus tear unattended, even if the patient is comfortable with it. So the patient always sometimes reads it online that some supraspinatus tears can be conserved. Yes, they can be, provided the tear is monitored and the patient does not lose his muscle bulk. Do not leave a patient unattended with an increasing muscle tear so that when he comes back to you the next time, he already has an irreparable or a huge tear, which is very, very difficult to repair. So just keep monitoring the patient. Sometimes the tears don't expand, they don't worsen, they remain the way it is. If they do and the patient is comfortable, yes, they can wait for a couple of years as well. So how do you come to a diagnosis? Always start with a history. For a patient with a rotator cuff pathology, always start with a history. Usually there is a history of fall, maybe on an outstretched hand, maybe have lifted some weight. In the times of Corona, they've actually started working more, they have started cleaning more, they have started lifting their arms to perform a lot of repeat overhead activities. Next, the patient may have onset which they don't exactly remember because they have performed thousands of activities. They don't exactly remember a particular activity which is led to this kind of pain in the shoulder. Or the patient may have a chronic pain since about 2 years and suddenly it has exacerbated. So that is an acute on chronic condition. On the symptom side, the patient has more pain when he tries to lift his arm. As I was explaining last time, the most important differentiation between a cervical spine and a shoulder patient is the pain they have on lifting the arm. So when a patient lifts his arm and has pain in the shoulder, it is pointing out to a shoulder pathology and not a cervical spine. Typically, night pain is most prominent in their history. Pain radiating to the arm. Cervical spine pain, as I said, extends up to the fingers with numbness, tingling, and neural complaints. If you see the shoulder, the patient, he typically complains of pain from the neck up to the arm. So if a patient complains of pain along the cervical spine, do not always assume that he has a cervical pathology. Sometimes supraspinatus fossa is painful and the pain does begin from the neck, but the neck movement is completely free. So it is a mixed picture which the patient will give you. The patient will say that my paraspinal muscles are completely paining, but my shoulder movements are restricted and my neck is completely free. In these situations, do not come to the diagnosis of only the cervical pathology, but shoulder can be the reason for the pain. Along with that, stiffness, as we discussed last time, stiffness is the most important point which cannot be missed. And weakness, patients present to you with a lot of weakness, then maybe it can be acute pain or it can be actual huge muscle tear. So how do you classify a rotator cuff? With the duration, etiology, size, and the degree. So the differential diagnosis, as I explained last time, most important for the rotator cuff is a cervical spondylosis. 90% of the patients always give a mixed picture. So always try and find out which is the actual cause of pain. I had a patient, so I'll just, is it okay if we have a little bit of a discussion at this moment? Prerak, are you there? Hello?
Yes, sir. Yes, sir.
Yeah, I'll just have a discussion at this moment. So
Please.
is there anyone who can just join me for the discussion?
Yes, sir.
Everyone can unmute. Provided there's no background noise, but whoever wants to have a discussion, ask me a question, please unmute and just interrupt me. It's fine.
Okay, sir.
So I'll just, I had a case, just after this webinar, I had a case actually present to me yesterday itself. And the patient had a 56-year-old female. She came from a reference. She came from a doctor who had already examined her before, gotten an MRI done for the shoulder. So she, sent me the report because in these times there's online consultations going on. She already sent me the report where the patient had cervical spine partial thickness tear with subacromial bursitis and bursal side thickness tear and all those kind of things. So she came with her MRI and she was sitting in the consulting with this. She was quite uneasy and she was sitting in the consulting room with her hand above her head, showing me the MRI for the shoulder. I was like, why are you keeping her hand over your head? She was like, that is the most comfortable position for me. So that made me think that the problem is not in the shoulder and it is mainly coming from the cervical spine. After that, we decided we'll just go ahead with a simple X-ray for the cervical spine. We didn't have to do an MRI. Even a simple X-ray showed all the changes of cervical spondylosis. The patient had no lordosis. She had degenerative changes. And it was very evident that the problem was arising from the neck. She also then started, realizing that yes, the neck movements have become stiff. And even though radicular pain was not there, it was typically a cervical pathology. So, even if the patient comes to you with a MRI report of the shoulder showing some sort of pathology, do not come to the diagnosis of the patient having a shoulder problem. Still keep your minds open to investigate and further